the acute coronary syndrome, you mentioned MI, right? Is that what I heard? Right. So ACS, good. So which would be MI. So let's put that at the bottom, like the most severe form, myocardial infarction, MI. Before I get to MI, which ones are they are less severe? Angina, good. So now we have Prince metal or vasospastic. It's now called vasospastic angina. We have the stable angina, right? And we have the unstable angina. Good. And then under MI, you can further divide MI into STEMI, right? And end-STEMI. End-STEMI, non-axis segment elevation, and then you have STEMI. Right. Very good. Let's talk about pathophysiology. What's going on in the vessel that will lead to these different types of manifestation? Because this is what your exam would do. This is what they're interested in first at this level, right? Basic science. What's going on in the vessels, coronary vessels? I will explain why. Some people present with maybe asymptomatic disease. Some have stable, some have unstable. Why do we have STEMI in some people and we have non-STEMI in some people, right? And before we do that, right, take note that what these three, right, unstable angina, end-STEMI and STEMI, right, they are the ones we call what ACS, acute coronary syndrome. ACS, yeah, acute coronary syndrome. They are the ones that can lead to like infarction or necrosis of the myocardium. Okay, so asymptomatic CAD is CAD that is due to what I call subcritical stenosis. So if people have subcritical stenosis, what does that mean? It's stenosis that is not causing any significant, right, ischemia yet. So basically, if stenosis is like less than 50%, right, if the coronary artery is like less than 50% stenosed, that's usually subcritical stenosis, although it can be up to 70% too. Yeah, but by and large, these people do not have any symptoms because the heart is still able, right, to compensate, extract oxygen, so no problem. However, if this goes on chronically, right, they can develop what heart failure eventually. Yeah, but these ones are very asymptomatic. What is causing the stenosis? It's typically atherosclerosis, right? So atherosclerosis, atheromatous plaque, that's what is narrowing the vessel. So we start with damage to the blood vessels and endothelium, and we form this atheromatous plaque, which is made up of a core of cholesterol, etc., and that can create like a speed bump, right? Yeah, in the lumen of the vessels. So if the luminal diameter is still like 50% to 70%, they're gonna be or less, gonna be asymptomatic by and large. In vasospastic, from the name, is due to vasospasm. So the coronary vessels undergo intermittent, right, vasoconstriction or vasospasm. During the vasospastic episode, patient have what's anginal chest pain, crushing chest pain, reducing to the arm or jaw. Yeah, but it's transient. That's the key. So symptom here. So the first one is asymptomatic. This one is transient symptoms. Transient, and it's gonna resolve by itself. During the episode, right? If you do ECG during vasospasm, there will be complete occlusion of the artery. So you're gonna see STEMI on ECG during episodes. But between episodes, normal ECG. Normal ECG. Yeah, for vasospastic angina. So typically young females or young adults at night, they have this severe angina chest pain. On the way to the hospital, there's STEMI in the ambulance. You get to the hospital, chest pain has resolved, you repeat the ECG, it's normal. You take them to the cath lab, you're going to see what? Subcritical stenosis. The stenosis will be, you might see some stenosis, but it's not going to be up to 50% stenosis. Yeah, likely vasospastic. angina. So, and we treat this with calcium channel blockers, right? Yeah, because that's to do with calcium. So that's that. I've seen question asked, if a patient has vasospastic angina, what other vasospastic conditions will they be at risk for? They may also be at risk for what? For Raynaud's phenomenon, right? Well, Raynaud's is a vasospastic disease, right, of the peripheral vessels, where whenever they're exposed to cold temperature, right, the vessels of the upper extremity undergo vasospasm, cause of blood flow to the hand, right, and the hand goes pale, becomes erythematous, etc., right, bluish, whatnot, yeah. So that will also be vasospasm. These people may also be at risk for diffuse esophageal spasm. There's also a condition that leads to vasospasm that affects the esophagus. It's called diffuse esophageal spasm. Yeah, so that's how they act this now. Because they know everybody knows vasospasm, you know how to diagnose it, you know it's transient, you know how to treat it like a calcium blocker. But you may not remember, oh, what other conditions are also due to vasospasm? Yeah, so Raynaud's phenomenon and diffuse esophageal spasm, right? Those are also other vasospastic conditions affecting other peripheral vessels and the esophagus, right? Respectively. So, and you can use the same treatment for all of them since they have the same mechanism, calcium channel blockers. All right. Stable angina. It's when the stenosis is what? Is more than 50%, but it's less than 70%. Yeah, stable angina. So now it's critical. It's more than 50, but it's not bad. It's less than 70. In the problem with stable angina is what? Is demand supply mismatch. That's the problem. They only have angina chest pain if the demand of the heart, right, for blood, for oxygen, right, cannot be met. Which makes sense. If there's narrowing of the vessels, whenever the heart needs more oxygen, we can't meet that demand. We can't get more blood flow to the heart. Then they have the words lactic acidosis and general chest pain. But then when the patient rests and demand drops, which means, right, the limited supply will be enough to meet demand and it resolves. We call it stable because you can predict, right, the level of exertion that will produce chest pain. So patient will consistently have chest pain with predictable level of exertion, and the chest pain will resolve with predictable levels of rest. Right. So patient will always have chest pain when they climb up 3 flights of stairs. And it's gonna get better when they rest for 5 minutes. Every time it's stable angina. The lesion is stable, the plaque is stable. That's why the presentation is stable. So the demand supply mismatch. This principle also explains how you treat stable angina. Because remember, if there's supply issue, right, which is basically you can't do much about it unless you go to the cath lab, right? You can't really do much about the supply issue, about the vascular occlusion. So what do you usually target? You target medication. You use medication to target what? Demand. If I can limit the demand for oxygen, the heart will always have a demand that matches what? The supply, the limited supply, right? And they won't have what? Episodes of angina. That's why you use what? So, and there are two ways you decrease. So, how will you decrease the demand of oxygen by the heart? Decrease work. The more work the heart does, the more oxygen it needs. The less work, the less oxygen. How will I decrease work? Two things: decrease volume, venous return, and decrease pressure. Yeah, those are the two kinds of work the heart does. So, volume work, pressure work. How will you decrease volume? Decrease venous return. Decrease the amount of blood returning to the heart. If less blood returns to the heart will pump out less blood, which means less work, less oxygen demand, less angina pain. So that's why we use nitroglycerin, nitrates, for angina treatment. Nitrates are what? Venodilators. they increase cyclic GMP through nitric oxide, right? And they're going to dilate the smooth muscles. They relax the smooth muscles of the veins. That will dilate the veins. When the veins are dilated, the veins have more capacity. Veins are like blood tanks in the body. When they are dilated, they have more capacity to hold blood. So they're going to hold blood, which means less blood returns to the heart, which means less demand, less work, less demand, less pain. Yeah, nitrates. How can you decrease pressure work? You can use beta blockers and calcium channel blockers. That's why I also use those to treat angina. That's how they work to help to treat angina. Beta blockers, calcium channel blockers. By decreasing the heart rate and contractility, right, you're decreasing cardiac output, which will decrease what? Mean arterial pressure. So if the pressure in the aorta is low, pressure is low in the aorta, which means the heart will do less work to pump blood out. The heart is doing less work against resistance, which means there will be less demand for oxygen, which means less pain. Yeah. So on ECG in patient with stable angina, ECG is usually normal, right? The ECG is typically normal, maybe normal during the stable angina, or they may have maybe end STEMI, but not necessarily segment elevation. But it's usually normal. Then cardiac enzymes will be normal since there's no what cell death yet. Yeah, so but it's predictable. So you know, okay, this is stable, no problem. The stable lesion causing critical stenosis, clinically relevant stenosis, but it's not bad enough, right? It doesn't ruptured, it's not severe, yeah, to cause infarction. If the plaque ruptures, so what happens over time? This plaque can rupture over time, can become unstable for different reasons. The thermomatous plaque can become unstable for so many reasons. Hypertension, patient is diabetic, hyperlipidemia, they have all these risk factors that's poorly controlled. Plaque keeps growing. There's active ongoing inflammation in the plaque. So what happens is the cap of the plaque can get thinner and thinner and thinner until it actually ruptures. Once it ruptures, it's gonna what? Expose itself to the blood, the core to the blood, and this core is thrombogenic. So platelets will bind to the core, to the ruptured path. And once they bind, they become activated. And what happens? They're going to worsen the what? The occlusion now. So a patient, the mechanism of ACS is what? Rupture of the atheromatous plaque with superimposed platelet clot formation, platelet thrombus formation. That's the mechanism of ACS, acute coronary syndrome. Because now, once there's rupture of the plaque and the platelet, you can see how narrow the lumina gets. It gets very narrow and sometimes can become totally occluded completely. In unstable angina, the mechanism is then ruptured plaque plus superimposed ruptured plaque plus platelets, thrombus. But now the occlusion is what? Is less than 100%. It can be up to like 90%. The narrowing will be up to 90% narrowing obstruction. And usually affects what? Affects like a single vessel, not multiple vessels. Yeah, a single coronary artery that is now about 90% obstructed. Still not 100% yet, less than 100%, but like 90% obstructed. Yeah, because of ruptured plaque plus superimposed platelet thrombus, you're thinking of likely unstable angina. Now, for end STEMI, right, it's like the same mechanism. Same thing as unstable angina, mechanism-wise. However, it's what? Multiple vessels, not one. So in unstable angina, in end STEMI, there's also ruptured plaque, platelet thrombus. There's about 90% stenosis. It's less than 100%, it's not total. It's 90%, but less than total. But it's affecting multiple vessels in end STEMI. So which means end STEMI is much more severe than unstable angina, mechanism-wise, because it's multiple vessels, which means higher risk of, the longer it goes on, the longer the risk of ischemia or infarction. And unstable angina is single vessel. It's not duration wise. It's short lived. And STEMI is much like severe. Multiple vessels and duration wise, right? It takes longer, so it's almost irreversible by the time we detect it. So what happens in both of them? Patient definitely symptomatic, right? ACS, angina symptoms, full on acute, sudden, crushing pain, blah blah blah. But then how do you tell them apart? ECG, both of them will have what? Either normal ECG or NSTEMI, which means the ST segment is not elevated in both of them. But then in unstable angina, cardiac enzyme is normal. So patient has ACS, acute coronary syndrome. There's no ST elevation on ECG, and the cardiac enzymes are normal. It's likely unstable angina, and it's unstable because now the pain is worse. This patient usually had pain after climbing up 5 flights of stairs, gets better when they rest for 5 minutes for the past 5 years. So it's stable angina. If once the plaque ruptures and becomes unstable angina, the pain will start with little exertion. They're going to have pain both at rest, or they're going to be having worsening pain with little decreasing exertion, and the pain will resolve with what? Longer period of rest. So now that's telling you, oh my God, this plaque is no more stable. That's ruptured. That is why this patient has had stable and predictable angina chest pain for the past 5 years now is now presenting what? Worsening, severe, progressively worsening chest pain. Pain that is happening at rest. Pain that is happening with little exertion. Pain that takes longer period of rest to resolve. Yeah, then you think, all right, this is unstable now. That's ruptured. If you check the cardiac enzyme and it's normal, you're still at the level, it's still early, it's affecting probably just one vessel, so they are still just unstable angina. There's no infarction yet, no cell death. But if it takes longer or it affects multiple vessels, then I'm still gonna see on ECG, you're gonna see there will be no ST segment elevation on ECG, but then cardiac enzymes will be what? Elevated. So now you're dealing with what? End-STEMI. Because in end-STEMI now there's cell death. The myocardial cells are dead. But since the occlusion is subtotal, only the subendothelial, right, myocardium will be affected. Not the whole thickness of the myocardium. Only the myocardial cells that are farthest away from the blood supply, right, will be impacted. And that's why you see end-STEMI on ECG. End-STEMI tells me that the patient has subendocardial injury. Only the subendocardial myocardium are injured or necrosed. That's why it's producing end-STEMI ECG. Yeah. And then cardiac enzyme will be elevated for sure because they are dead. Cellular proteins will leak out into the blood. Yeah. Then if it's STEMI to ruptured plaque, it's going to be a ruptured plaque plus superimposed platelet thrombus. But now the occlusion is what? 100% occlusion. Total occlusion. Which means every cells in the myocardium is susceptible to injury, this infarction, right? So that's what, so, and you're going to see, what we're going to hear, we're going to say transmural infarction. Transmural myocardial injury, the whole thickness of the myocardium will be infected, which makes sense. There's no blood flow whatsoever, zero blood flow. So every cell will die in the myocardium. Not only the cells farthest away, right, from the blood supply. Yeah, every cell will die. So, and you detect that transmural infarction, right, as STEMI on ECG. You see ST segment elevation on ECG. So I call this STEMI, ST segment elevated MI. And then since the cells are dying for sure, cardiac enzymes will also be what? Elevated. Any questions on this? Okay. If you're giving a patient with MI, and they ask you, right? This question is for Victoria. Why am I detecting? Why are we detecting cardiac enzymes in the blood in myocardial infarction? Why will it detect? What is going on at the cellular level that will lead to high cardiac enzymes in the blood? Okay, so what's going on with the cells? Yeah, there's thrombosis, there's obstruction of the blood vessels, there's ischemia, all right? But what happens to the cell? What cellular changes with this? If you look at the cell, the myocardial cells, what change will they undergo that will explain why I'm detecting troponin, CKMB in the blood? Okay, Kentasha, you were about to say something? Exactly, cell membrane. Good. Right. Remember, Victoria, where are these proteins normally? They are in the cell. Right? Cardiac enzymes are normally in the cell. They are intracellular proteins, not extracellular. They shouldn't be seen in the blood in normal people because they are cytoplasmic proteins. Troponin is in the cell, in the muscles. CKMB is in the cells. So why would I see them in the blood? The only reason is if the cell membrane, which normally separates the ICF from the ECF, right, has ruptured. That is why intracellular content will leak into the what? Into the ECF. And we can use them as a marker of what? Of cell death. Necrosis. Does this make sense? Okay, that's important. That's yeah, general principles at best. So follow-up question. How will they rupture? Yeah, that's follow-up. How will ischemia lead to cell membrane rupture? Why would ischemia lead to cell membrane rupture? That's the next question. How? Anyone? Why why will ischemia lead to cell membrane rupture? Okay, okay, good, good. So good. No blood flow, ischemia or hypoxia, no oxygen, no ATP, right? There's no ATP, and also lactic acid will be accumulating, right? Anaerobic respiration. So it explains why if you see a cell that is dead, necrotic cell, what does the cell look like? The lactic acid denatures the protein in the cytoplasm. So the cell looks pinkish. Also, the lactic acid can degrade the nucleus, karyorrhexis. So you're going to see those cells, they look pinkish and anuclear. They don't have any nucleus. And they look pinkish, diffusely pinkish cytoplasm because proteins are deformed or accumulating in there, right? Deformed, basically. If that process goes on, if another thing is if ATP is low, sodium potassium ATPase, right, will stop working. Remember all those primary active transporters, they are the ones that use a lot of ATP in the cell, massive amounts of ATP. Sodium potassium ATPase, calcium ATPase, right? Both of them stop working. So what happens? Sodium accumulates in the cell, calcium accumulates in the cell, and water will follow. So water follows, the cell swells up, right? And the cell swells, so you are not going to see what the hydropic change or cellular swelling at that point. If the cell keeps swelling up, eventually it can contribute to what? The rupture of the membrane. Then the enzymes too that are there, calcium accumulating in the cell too can activate what? Enzymes in the cytoplasm. The lysosomal enzymes can be activated, and they're going to contribute to what? To enzymes like phospholipase will contribute to breaking down the cell membrane also. Yeah, and then eventually the content of the cell will leak out into the blood. And we can use those contents to clinically determine, right, if somebody has necrosis or cell death. And if they do, which cells are dying. So that's the basis of having like liver function test, AST, ALT. Yeah, they leak out whenever the hepatocytes are dead. ALP leaks out when the biliary cells, cholangiocytes, are dead or damaged. CKMB troponin leaks out when the heart is dead. Creatine kinase leaks out myoglobin. Creatine kinase leak out of muscles, skeletal muscles as well as cardiac muscles, right? When they are dead. Rhabdomyolysis or necrose, yeah. So we use all those, right, to tell us, okay, right, the cell is dying as well as what cell is likely, right, dying, because we know necrosis will lead to cell membrane rupture. And once the membrane ruptures, the leakage of those cell contents into the ECF is also a trigger. It's like an alarm system. Not only do we use the proteins, right, to tell us that cells are dying, the bodies will respond. The bodies will respond. The proteins leaking out will trigger acute inflammatory response. Basically, acute inflammation is what? The body's response to injury, of cell injury. So if some cells are undergoing necrosis, how do we know? The content in the cell is leaking out. Those things will activate what? Immune system, innate immunity, phagocytes, dendritic cells in the tissue, and they're going to trigger neutrophil, right? Infiltration. So neutrophils come in, they're trying to take care of the damage, trying to find and destroy microorganisms, right? Right. Trying to break down any dead tissue and stuff. And that will take about day 1. That will occur between day 1 and 2 after necrosis. Then from day 3, what will follow neutrophils? Macrophages come in next. Macrophage will come in and eat up, right? They are the clean up crew. They are the bridge between necrosis and healing. So macrophages come in next, day 3 to 5, and they start eating up, right? All the dead and dying tissues, all the dead and dying neutrophils, all the dead and dying connective tissue and cells. They eat them up, clean up the area, and then they activate what? Fibroblasts and angiogenesis. So by day 7, fibroblasts come in. 7 to 10, fibroblasts come in, and they're going to start laying down what? Granulation tissue, which is type 3 collagen and blood vessels, angiogenesis, all the way to like day 14. Then after that, then the scar tissues start undergoing what? Like remodeling, right? Granulation tissues are undergoing remodeling. You convert the 3 to type 1 collagen, which is much stronger. There will be less blood vessels, there will be less cells, and then we have the strong scar tissue, right? Yeah, to maintain the structural integrity, right, of the organ. But the functional integrity will be low already, because we are replacing the functional cells, dead functional cells, with what? With a non-functional, right, collagen. Yeah. So what I just did right now, right, that is the evolution, right, of MI. Within 24 hours, you're looking at hydropic changes. You're looking at, right, those things we talked about, cell membrane rupture, pinkish cytoplasm, etc., coagulative necrosis. Yeah. 1 to 2 days, neutrophils come in. 3 to 5, macrophages. 7 to 14, fibroblast granulation tissue. After that, scar tissue. Yeah. It is not a coincidence. If you look at the complications of MI, post-MI complications, it is not a coincidence that most mechanical complications of MI take place in what days? 3 to 5. or up to 3 to 14, maybe. But typically, most commonly between these 3 to 5. Why? Because that is when the heart is at its weakest, right? That's when macrophages come in and start eating up everything, all the dead tissue. And we haven't laid down collagen yet. So that's why you're going to see a lot of ruptures, papillary muscle rupture, leading to mitral regurg or valvular regurg, valvular insufficiency. You're going to see the interventricular septal rupture leading to VSD. That's why you see free wall rupture leading to cardiac tamponade, right? It's usually between these 3 to 5, because that is when the infarcted heart, right, is at its weakest point, basically. Yeah. So that's that. Any questions? Okay. So yeah, I think right. Go ahead. For so in ACS, the drugs that we can use. So your two goal first objective is what, minimize or slow down the ischemia, slow down cell death, and that's the first objective or major objective. And how do we do that? We can do that by decreasing the demand for oxygen or increasing oxygen itself in the blood, and then limiting the ischemia, limiting the progression of the ischemia, right? And restoring perfusion as soon as possible. So that's why the medical treatment for ACS, acute coronary syndrome, either unstable angina, STEMI, NSTEMI, what you do, so this Monabashir, right? It's like a way to kind of just quickly remember the drugs that we use. And M for morphine. So if the patient has chest pain, you can give them morphine for chest pain. Remember, pain itself can increase, right, sympathetic tone. By controlling pain, you decrease sympathetic tone. You also, morphine too can decrease venous return. So I'm decreasing work of the heart, decrease heart rate, decrease the venous return, decrease the volume work, which means the demand for oxygen goes down, and that will slow down, right, cell death. You can give oxygen to make sure there's proper oxygenation if the patient has low PaO2 or SpO2. N for nitroglycerin, nitrates. So give nitrate. Nitrates also what, venodilators, right? You decrease venous return, you want to decrease volume work, decrease the amount of blood return to the heart. If I decrease volume, less blood being pumped out, less demand for oxygen, slows down, right? Cell death also, and extent of damage. Then now you target the block. Aspirin usually gives people dual antiplatelets. Remember the pathophysiology of ACS. There's rupture of plaque with what, superimposed platelet thrombus, right? So you give aspirin and clopidogrel, antiplatelet. So these guys, they decrease the block, decrease ongoing thrombus formation, which also slow down, right, cell death, decrease ischemia. And then B for beta blocker. Beta blockers, they give them to also what, decrease what, heart rate, decrease contractility, decrease cardiac output, which also decrease what, pressure work. So the heart is doing less work, decrease demand for oxygen, that will slow down, right, cell death. You can give aldosterone receptor blockers, especially in people that also have heart failure. I'm going to tell you the function of that later. Let me put this here, ACE inhibitor, ARB. Yeah, we can use that especially with heart failure. I'm going to tell you why that is important later, soon after this. Then we have statin. Statin to will slow down, right, the block. Remember the atheromatous plaque that we're dealing with, right, it has cholesterol core. So by giving statin and decreasing cholesterol, right, that decreases the ischemia. Then you can also give heparin. Heparin too can help, right, break down some of the clots and restore perfusion. So you can see we can basically divide the overall medical management, so based on the pathophys, right, to things that will slow down the ischemia. How do you slow it down? Reopen the blood vessels, right? Or slow down the thrombus, platelet thrombus, or you slow down the heart's demand for oxygen, and then improve oxygenation so that we can deliver more oxygen, right, to the heart. So once you do this, then you have to get them to what? Break down the clot as soon as possible, right? So you can do like TPA for STEMI, actually where there's total occlusion, you must break the clot. So for STEMI, so TPA, or you do them to the cath lab, right? Catheterization, where we mechanically break down the clot and reopen the blood vessels, yeah, if they present early. So early reperfusion, super important in STEMI, yeah. So that's that. Now, second concern after MI is cardiac remodeling. So what happens with these people is, over time, right? Remember what happened. The heart will patient lost functional cells, and those cells are replaced by what? Collagen. So that is cardiac remodeling basically, and this can continue over time, where the myocytes will be dying, and again be replaced by what? Fibrous tissue. Some myocytes will still keep undergoing like apoptosis, programmed cell death over time, right? And going to be replaced by what? Replaced by collagen. So over time, the patient will be losing cardiac function, right? Progressively until they go into what? Full-blown heart failure, and they can die. And this is one of the most common cause of mortality, right? After MI. So you have to target this. How do you target this? The mechanism of cardiac remodeling, right, is sympathetic and RAS, which makes sense. Patient has MI, cardiac function goes down. That will act like we said, pressure goes down, right? Like from our formula before, right? RAS will be activated to compensate. The problem is once they are activated, right, they actually what? Lead to cardiac remodeling. All those aldosterone, angiotensin, catecholamines, right? They can induce cell death in the heart and replace the cells by what? Fibrosis. Yeah. So this is the mechanism of cardiac remodeling. So to slow down cardiac remodeling and improve mortality, if you're given a question saying which of these drugs will improve mortality in patients with MI or with heart failure, which of these drugs will improve survival or decrease mortality, you're looking at drugs that are what? Slowing down cardiac remodeling. How will you do that? Target RAS. So this is where on our monobatch C, right? Aldosterone blockers, inhibitors, ACE inhibitors, ARBs, they're going to slow down cardiac remodeling, as well as renin inhibitors. Then target sympathetic, block sympathetic, so your beta blockers. Yeah, so these guys, they have the added benefits, right, of preventing long-term cardiac remodeling, right? Yeah, and subsequent mortality in people with MI. Yeah, but this is how you